Hi, everyone, and welcome to our Wound Care Pro series brought to you by Wound Care Pro app. And it is founded by Ann Walsh, and she is my co host for this amazing series that we have every week. That if you are not watching this live, you can always go to youtube.com/, the weight of my heart, click on our live button, and you will see a promotion every single week for Ann Walsh's series, Wound Care Pro, so that you are ready to know what topic we're going to be discussed and come armed with questions for Ann. Get your questions answered. Thank you so much, Ann, for volunteering your time and taking time out to provide such critical education, because it's just not out there, and you're democratizing the most advanced education on taking care of wounds for both clinicians, physicians, as well as patients. So we really appreciate your dedication to improving the education and care for patients, especially their wounds.
Sure.
So today we are going to be talking about pressure wounds. Now, this is literally a huge topic. Um, I'd love to get into what makes something a pressure wound versus a different type of wound, and some of the different types as well. And then we're going to get into, I have some experiences with patients that have had serious situations with pressure wounds, because a lot of our patients are peripheral artery disease patients, or diabetic patients that end up with a lot of neuropathy on the numbness side. So they don't feel when their shoes aren't fitting right or whatever. So let's start with just the definition of the pressure wound and the types of pressure wounds that we can get.
Yeah, so it's the new term is pressure injury. And basically it's from unrelieved pressure. So if somebody's, let's say, in the hospital or they're home and they're not, doing well and they're confined to bed and they're not able to turn and reposition themselves, the skin could actually start breaking down because you're exerting pressure on, let's say, the bed, and the blood flow can't get in. Then over time, the tissue can die. And now you have the start of a pressure injury. And it may just be a stage 1, which is sort of the reddish area on a light-skinned person you could see. Somebody darker skinned, you may not pick up as easily if you don't monitor, like, is the area tender compared to the adjacent skin? Is it darker or lighter? And that would be a stage 1. And then it could progress to 2 and 3 and 4, which is deeper. And it could happen rather quickly if somebody's frail and has poor nutrition and other factors, incontinence and that sort of a thing.
It is so important that you mention people of color and how difficult it is to spot some of these wounds, and especially the start of something, of these pressure wounds in particular.
Yes.
We had a podiatrist on recently that was saying one of the issues that she has, and she is a person of color, one of the issues that she has as a person of color who is a podiatrist is she finds so many patients coming to her who are of color as well, that they didn't have their diabetic ulcer, for example, spotted a lot sooner. And she said one of the problems is that in medical school, or even at some of the continuing medical education events and conferences, they don't have a lot of cadavers that they provide that are people of color. And she doesn't know why, except maybe she thinks that we need more people of color to devote their bodies to science. I don't know if that's a problem. I've never really looked it up. But it's really important going forward that our physicians and clinicians get more experience, don't you think, with
Absolutely.
people of color, because that is a huge disadvantage.
Absolutely. By the time they're discovered, they're later stages, stage 3 or 4, and everyone's like, oh my God, never saw that coming, if they're not knowing how to tune into a good assessment. If you go to the home, you're seeing a patient and you turn them over and you want to look at the skin on the sacral area where a person's spending a lot of time oftentimes if they're in the bed. And if you don't catch it, that, hey, wait a minute, I'm not seeing redness, but let me ask the patient any tenderness and these kinds of things to hopefully catch it early and get them off the area and so on.
Good point. Would you mind repeating that? if you are a patient and you are bedbound or either at home or you're spending an extra amount of time in the hospital because of a procedure or pneumonia, some other illness, whatever it might be, what are the questions that you should ask when your clinician, whether it's a home care nurse or a nurse inside the hospital, comes into your room or into your home?
We should make sure that they're assessing because you can't see your back area yourself. So if you're being, you're asked to have them to help you turn if you can't turn yourself, or if you can, you could have them look at those pressure areas, any kind of bony areas like the sacral area. And again, if one is lying on their back, you may not, and then you could say, if especially if the patient feels something, oh my God, it feels different back there, maybe a little tightness or tenderness, and then have a clinician or a family member look and see, do they see anything changing, or have them feel the area. Is it hotter than the adjacent skin? And that may be the start of a pressure injury. So to get off the area, and hopefully it'll resolve before it's gets further along.
We had a situation recently with a patient at a large HMO in California that the doctor wanted to perform an invasive bypass, which most doctors would consider palliative care, the last hurrah, Hail Mary of all Hail Marys,
Yeah.
and wanted to corner the patient into making that drastic decision to have this bypass performed. It's called an axillary bifemoral bypass, which attaches from the shoulder to the groin or both groins, and then ends up rerouting blood flow around typically a block by aorta into the legs. Now, typically, a doctor usually does this if there's an infection nowadays in the aorta and they just need a temporary solution, heal the aorta, get those antibiotics in, and then they can go ahead and revascularize or recanalize the native vessel and open up the aorta. But this doctor wouldn't hear it, so the doctor said, okay, well, until you decide to do it, you're just going to sit here. So we got involved, and it took literally 5 days of this poor patient sitting in there with no blood flow. They just left her there until she would come around, is what the
Wow.
doctor had said. And we were able to finally get her a second opinion. The problem was the weekend in between. Get her a second opinion in there. And they were able to say, what the heck? Why would you do that major bypass when we can just go in with a little catheter delivery of clot busting drugs, a thrombectomy device to suck out the clot, and you'll be fine? Well, by that point, she had already developed a pressure wound.
Oh, wow.
And I would wonder if it was exacerbated, like the potential for it or the risk of it was exacerbated because of no flow through the aorta. I'm really curious about that. But, it was great. We got her wounds healed, but I mean, her legs back to normal, blood flow. But man, it was literally, it took weeks
Oh,
and
yeah.
weeks to heal this awful pressure wound on her butt.
Right. And, especially if the person's, if they're wheelchair bound, or, just when you're sitting, it could be a very uncomfortable. So it's a, quality of life issue. And the more you're sitting on the area, the more the healing potential is decreased. You need special cushions, and you need a special mattress on the bed, all these kinds of factors to get try to offload that pressure and hopefully get the blood flowing again.
And I would imagine that people who are vasculopaths are at greater risk of having pressure sores
Absolutely.
because they already have struggles with blood flow. They're already limited in so many different areas and depending on collateral vessels, which may not be enough.
Absolutely. And, oftentimes somebody may go in for a hip replacement, we'll say, and nobody floats their heels off the bed. A simple thing, put a pillow there, and then they have this horrible pressure injury on the heel, which is a very difficult area to heal. Because even if you have good pedal pulses, not necessarily getting blood flow to the heel. And here they are, the surgery went well, but now you have this other problem. So it's just important to know those simple sort of techniques, get the pressure off those bony areas with pillows and whatever, so that you don't have come out of a surgical procedure with more problems.
Do you find, and this is kind of a strange question, do you find that people who are thinner have more risk of getting these pressure sores versus someone who has a little extra meat on the bones?
Yeah, definitely in certain parts of the body, but I think we often get surprised with sometimes a patient may be obese, but still be malnourished, In other words, their protein levels might be low. And you're looking, why is this person's skin breaking down so rapidly? They look, healthy. And it's a, sort of, I wouldn't say fallacy, but the person could be malnourished. So it's not just looking at them, just, getting the blood work and seeing if they have all the right stuff. So I remember a situation like that. And I was like, why is this lady? Then her albumin was 2.5. It was so low, yet she was a big lady. So her skin was breaking down until we corrected that. And, it was part of our plan. And then she healed eventually. But
It's interesting. Deficiencies can actually increase your risk of
yes.
having.
Yeah. Like if somebody's anemic, you're not getting that oxygen carrying, those red blood cells carrying the oxygen to the skin. So that person's at risk. If they have heart failure and they're not, or COPD, you're not getting the oxygen, they're at risk. And so it's a lot of factors that come into play. Absolutely.
So Marcia, go ahead and unmute. Marcia has a question for you. And again, if you do have questions for Ann, always go ahead and make sure, if you're on YouTube tuning in, go ahead and place them in the comments section. And if you're watching live, we can get to them now live, or we can actually get to them next week, or you can tune in next week and ask them yourself. But Marcia, go ahead, ask your question. You're live in our live studio audience.
Thank you, Kim. And thank you, Ann. Okay, so I have PAD and I'm pretty high achieving as far as like I walk a lot and stuff. And I'm maintaining, but in the spring, I have a farm, and out front by the road, it's all grass and very heavily treed with old trees. So we had storms and storms. Well, in order to mow, I had to pick up sticks. And I mean, for days, I was out there picking up sticks. My problem is that when I would walk, every time I'd bend over, I would push like this part of my foot, just the way I was bending.
Yeah.
And it got so sore. And I tried to get an appointment with a podiatrist. I couldn't get in anywhere. I couldn't get help. I was getting bunion pads. And finally, I was just like, okay, the grass will have to go, just climb. I have to stop. It was scary. And it's happened a few times since, not as extreme as that time. That time it was looked like it was on fire.
Oh, wow.
And just that repeated motion. And I don't know if that's a pressure, whatever you were called, pressure wound or
Pressure
not, or the
injury,
beginning. Yeah. And I'm just wondering would that be what you're talking about, even though I'm mobile?
Yeah, I mean, a lot of times we see on the feet, we're looking more at sort of neuropathic ulcers or arterial, because you're getting that pounding and you don't have maybe enough blood flow. But do you have a good fitting footwear? Have you been fitted by the podiatrist?
Yeah. It was the repetitive movement, and it was like on that bony side part of your foot. It was just, I was constantly going like that, and it wasn't used to it.
Yeah, you certainly do get a pressure injury there, just if it's a bony prominence and the pressure is constantly being put on the spot, definitely. So
and what can you do for that?
Some kind of offloading. So I just would wonder if your footwear is supporting you enough to accommodate for that area.
It is. I mean, because I walk a lot and I wear the same shoes. It was just that movement, but I had to do it. I had to clean up my storm mess. So what do you do? Just quit doing the repetitive movement?
I mean, you could try to pad the area if they're new shoes, kind of, break them in or whatever, because if you are putting pressure on new areas of your foot that you're not used to, but definitely padding the area. If you're seeing red and you're feeling pain, like, to stop and protect the area as best you can before that repetitive motion breaks the skin down. We even had a lady that they took her to get her nails done. And I guess there was filing a callus, and she ended up getting this horrible arterial ulcer, we called it, on the side of her foot because the blood flow wasn't there. And that's all it took, is that shaving that callus, and then she opened up. And we had to get
I felt like I was a hair away from a disaster.
Yeah. Oh yeah. Yeah. Well, it's good you knew when to stop then and try to, rectify the situation a little bit.
But then this next spring, the same thing's going to happen because it happens every year.
Yeah. Oh, well. Maybe do it in batches. I lived in Ireland, so I know I was on the farm myself for years, but, just maybe do it rather than repetitive motion for hours on end, maybe try to do it in stages, give yourself a break, see if you need a little padding on the area with some gauze or something before going forward.
Thank you. Thanks, Kim.
Oh, you're welcome.
Thank you. And Douglas, go ahead and unmute, and you can ask Nurse Practitioner and Walsh your question.
Yes, ma'am. Good to see you again. So when you're talking about the pressure wounds. Also, when I'm talking to people in the in like through the Leg Saver hotline, and we discussed this with the colored people, are you saying that it's just hard to see the beginning of a pressure wound because of the skin color? Are there
Exactly.
other things you can look at if you're trying to describe this to a colored person? Are there other things, or is it just the color?
Yeah, I think the color is just like, we've been trained, we'll say medical and nursing or whatever. If you see any redness on the skin, that could be a stage, lead to a stage 1 and then get worse. So if you're looking for that in somebody's darker skin, you might like, oh, I don't see any redness. You may not see any redness. You have to ask, do you feel any pain anywhere, or look at the skin in these bony areas. If it seems darker or lighter than another area that's not exposed to pressure, it may clue you in, hey, something's going on here, rather than waiting till the skin breaks down, because you don't have that like bright redness in your face that you can kind of intervene quickly. So just to know that, and just have the person, any areas of the skin that are hurting or feel different, or when a nurse or somebody's evaluating, they feel it with the back of their hand. Oh, this area feels very hot. Could be there's a lot of pressure on this site. Let's try to get off it. So just like the color, that it's not so obvious if we don't dig deeper, if somebody has darker skin tones.
Okay.
Awesome. So can you talk about some, all of the different areas that you mainly see these pressure sores? I know we've hit, a few of them, especially in the sacrum, and we've talked a little bit about the feet, but it'd be great if you could just run through the major areas that are most susceptible to pressure sores and why.
Yeah, I mean, the sacral area, because most people, if they're in bed and they're bedbound, they're going to be laying on their back. So that area gets a lot of pressure, especially if our patients, if you need the head of the bed up, so it's easier to swallow and breathe if they're at risk for aspiration. So that's putting more pressure on the lower back. So it's a high risk area. And if somebody's incontinent, that's the area exposed. So that's a big spot right there. But also the hips, because if we tell people, oh, turn them side to side, if they don't sort of turn them correctly and they put them 90 degrees on the hip, now the sacral looks good, but now the hip is going to break down. So it's sort of a technique of putting a pillow behind the person so they're not 90 degrees, but they're tilted, let's say 30 degrees from side to side. It just, and a clinician could teach, just to make sure somebody's doing it right. So the hips, the sacral, the shoulders, if somebody puts you 90 degrees, the ear, the shoulder, the elbows, so any of those kind of bony areas. And the ear is a very tough spot, because sometimes if a patient can't like support their head and they're lying, putting pressure, it could be down to cartilage before you know it, because there's no fat there. So those are tough spots to heal and offload. Sometimes we'll use a neck pillow, try to help the person get the pressure off. But those are the main, like I said, the hips, the sacral, the heels, the elbows, the shoulders, and even the back of the head sometimes, if someone's not careful, you can get a pressure injury there. We've seen them sometimes.
Oh, wow. And if people want to learn more about this, I would imagine it would be a popular spot on Wound Care Pro if they download your app, and they would have access to a lot of this information on how to prevent, how to manage people who are at risk of, especially.
Yeah, no, I definitely put in there just the risk factors, how to address nutrition and incontinent care and all these things. I put a link also to how to properly turn and position a person. And that's from the National Pressure Injury Advisory Panel. So they put a nice little 2-minute video, just because if somebody teaches somebody how to turn, they'll just flip them to this side and flip them that side. And, you might be getting the pressure off one area and putting it on another.
So in order for a clinician, especially to start there, to treat a pressure wound, especially when it's on the back, might be on the ear, it might be on the head. I mean, your number one rule is, okay, how do you prevent it from getting worse? Let's focus there first. How do you prevent it from getting worse, and how do we make sure that in preventing that from getting worse, we don't cause another situation in another spot, right?
Right. I mean, the main
Okay.
goal is try to get the pressure off. Not so easy if it's on the back, but you want to, use pillows or turning wedges to try to tilt the person so they're not flat on the back. So getting the pressure off is key. Treating incontinence if the person is, like, let's say with the zinc oxide or some kind of moisture barrier, so they're not like, the skin's not moist, much more easy to break down. Also nutrition, if the person's malnourished, skin's going to break down rather quickly. And mobility, getting other groups involved like PT, OT, get the person up where possible, because those are all the things: poor mobility, incontinence, poor nutrition. If the person's sliding down in the bed, they're getting shear injuries as well as pressure, and the skin could break down very easily from that. Sometimes medications, if somebody's on steroids, look and see, do they still need them? Because the skin may be bruising easily and more frail, and a lot of these blood thinners too. But, it's a balancing act. Is it helping? Is it, hurting? Sometimes, because lately we've seen a lot of bleeding wounds this week, with skin tears and stuff like that. And if the person's, we'll say, upper 90s, we just say, do you really need this particular anticoagulant at this point in their lives? Because it's causing them such distress. One skin tear heals, another one breaks down, and they're bleeding, and everyone's alarmed at the amount of blood. So we have to look at the whole picture, what's going on with the person.
Yeah. And so is there any different way that you would treat a pressure wound versus other types of wounds? Anything special that you need to do to make sure that you are taking care of this particular wound, this pressure sore, right?
Yeah, I mean, we'll assess the wound like any other wound. What does it look like? Is it clean? Does it need to be debrided? How much drainage is there? If there's minimal drainage, we're going to look at dressing to hydrate the wound, because you really want to have that moist wound healing. You don't want it too wet or too dry. If it's more heavily draining, then we're going to look at the absorbent dressings on the market to, pack that wound or cover that wound. If it's in an area exposed to incontinence, there's a lot of outer dressings that are waterproof. Try to cover it with that to seal out the incontinence. So there's lots, it's all depending on what we're looking at and where it is on the body and that sort of thing. If it's on the
So,
legs, I try to avoid tape on the skin, because if you've got
oh,
poor vasculature, then you may heal the wound and then you give them, a skin tear from the tape, let's say. So.
And so if you are a patient, you are at home, you have peripheral artery disease, you likely have diabetes, how would you suggest treating some of these pressure wounds? I mean, you have two different kinds. One, I mean, you have the ones that may not have broken through the skin yet, right? And then you feel the tenderness and you think, uh-oh, what's going on? And then the second aspect is, okay, more advanced stage, it's broken through the skin and we need to prevent infection, or it's already infected. What do we do?
Yeah, so there's a lot of dressings on the market that are antimicrobial if it does appear infected. If it needs to be debrided, we could do that. And another important thing is getting the support surface on the bed. So if the person is spending a lot of time on the bed, there's different levels of a support surface. Like a group 1 would be like a gel, memory foam type of thing on the bed, or an alternating pressure pad overlay that goes over the person's mattress. Plug it in, and one pocket inflates while the other one deflates. If it's more serious wounds, then they have what they call a low air loss mattress. They'll replace the hospital bed mattress in that case. And, they still have to be turned, but it takes a lot of the pressure off, at least, it's more, less likely it's going to, worsen, or more skin breakdown going to happen. But again, you still have to be turned, but it just takes the edge off.
Yeah. And I think Douglas might have another question. Douglas, go ahead and unmute and go ahead and ask nurse practitioner.
Yes, ma'am.
Oh.
My brother has a handicapped child, and when he has his moments, I was there when the lady said the number one thing through the day was to keep changing him positions, and they put him on the schedule through the day. And I do remember her saying something about lotion, not to put too much lotion on, because it can be just as bad. But the number one thing he had to learn was to rotate Charles on a regular basis. And they did teach him where the pillows went, and you need to ask those questions, don't you?
Absolutely, yeah. And usually we say every 2 hours. I mean, as best you can. Sometimes we say 2 to 4 hours to rotate that person. Sometimes people use a clock and they're like, okay, they're at 12 o'clock, and then they turn them in 2 hours and that sort of thing. So they're on the right side, the left side, depending on the time of the day. They're on their back. So it's not easy, but that's a very important part of it. Because if you're lying on the same spot, then it can never get better. It's only going to get worse.
And just as we finish up the last few minutes here, gosh, this has been just a wealth of information. I think it's going to be so helpful for people who are dealing with pressure wounds or have, family that have just gone to the hospital and they might be at risk of it. And you're giving them so much information that they can actually take preventative, measures and ask the right questions to make sure to prevent their loved ones, or at least mitigate the risk of their loved ones getting one. But I'm curious from your perspective, because you're on the cutting edge of wound care, and you have your app Wound Care Pro, where you're trying to in real time, input all of the latest information, the latest research, and cutting edge approaches, tools, techniques. What do you think is still missing? Where are these gaps when it comes to pressure wounds that you're like, you know what, why can't someone create this? Or why isn't this moving through the approval process faster, because we need this today?
Yeah, I mean, it's pretty complicated because even they have, alarms, and they've even turning beds that'll turn the person, rotate the person. But then people fear that, nobody's going to go take care of them. Like, oh, they're on that bed and they're good to go. But you still have the incontinent care. You still have to worry about the lungs and sit them up and do everything. So it's hard. There's so much. And then we see people, living longer, all these comorbidities. If somebody goes into they're on vasopressors, let's say if their blood pressure drops, that shunts the blood away from the skin in trying to save the heart and the lungs and the brain, and then the skin breaks down. So it's a balancing act, but it's a lot of moving parts. It's a whole team approach. Get that person moving as soon as they can. Somebody's got to be turning them. Has to be using moisture barrier ointments to seal out any incontinence. And nutrition is huge. Get that
Yep.
registered dietitian in there. So it's all these things. Even if you're trying everything and the protein is so low in the body, it just doesn't take much. Somebody can make it break down in a matter of hours, depending on how
It's
their system is.
it's important that you brought up about the vasopressors. We've seen over the past year, 4 patients lose all 4 limbs
Yeah, yeah.
after being on an ECMO machine, the artificial lung. They came down with some random virus. They didn't know. One of them actually had a UTI that
Oh, wow.
ended up, the patient went septic, and in order to save their life, the patient was on an artificial lung and an ECMO machine. And then on top of that, to raise the blood pressure, they ended up putting them on vasopressors. But all of that really, you have the artificial lung that can cause clotting, right? Then you have the vasopressors that are maximizing the blood flow, as you said, to the heart and the other organs at the expense of your limbs. And so it's really important. I know, in these situations they're in the ICU and it's tough to monitor, but you do have to make sure that that patient is moving. And one of the tips that an ECMO specialist told me was, and I don't know if this is the same or if there are protocols or if it's allowed anywhere. I'm curious what your experience is, but they said that you need to have someone in there moving their arms and legs a lot, like every couple of hours. They need to be moving those legs back and forth, not rubbing them up against the sheets, but taking them a little bit in the air, moving them back and forth, moving the arms back and forth to try and make whatever blood flow they do have in those limbs, maximize them. And
Yeah.
we always talk about movement grows collateral vessels. Well, it's probably the same in that case. The more you move, the more you're able to get that blood flow moving, whatever you do have, right?
Absolutely, yeah, and turning and repositioning a person every 2 hours or so, maybe more in certain situations, less in other situations, because it's tough because you don't want to keep the person up all night. Turn them every 2 minutes. Sleep is important too, but it's that turning and repositioning, and then all these other factors, like I said, the nutrition and everything else together. Because we see some bad pressure injuries. We've seen that some of them heal beautifully over time, but it's tough. It could be down to the bone before you know it if somebody's really in bad shape.
And I would think that especially if someone is susceptible to these pressure injuries, there have to be some sort of nutritional shakes, Abbott's Jervy, things like that, that might help to maximize the nutrients that you can get to prevent these types of things if you are in a dire situation where you're not moving very much, right?
Absolutely, yes, yes. And if a person's not swallowing properly and they're aspirating, they can't eat regular food, then getting these nutritional supplements is a way to get that protein in them and get all these vitamins and minerals.
Well, thank you so much, nurse practitioner Ann Walsh. These half hours, literally, they go so quickly, and we appreciate all of your time. And if you want to learn more about how to prevent, how to treat, and how to manage pressure wounds, make sure you do go to the App Store, go to iOS, go to Google Play, and download Wound Care Pro. It's $4.99. It's mainly meant for physicians and clinicians. It'll really, really help you because not enough clinicians and physicians are wound care certified. So this will definitely help you in managing these patients. So download woundcarepro.com. Thank you again so much, nurse practitioner Ann Walsh. We appreciate you donating your time and providing such critical information for us.
Thank you. My pleasure. Thanks, everybody. Have a great evening.
You too.